sitting in a room together and that I can hear you and that you can hear and see me, and we can have a little bit of an exchange. So let's start some true or false questions. You can identify someone struggling with an eating disorder by looking at their appearance and observing what they do or do not eat. So I'm going to pretend that everybody is resoundingly saying, oh, of course not. That's false. It's a pretty common assumption that you can tell just by looking at someone whether or not someone has an eating disorder. And the reality is eating disorders affect individuals of all ages, gender expressions, sizes, weights. We can't tell just by looking at someone that they have an eating disorder. Approximately 70% of individuals with bulimia nervosa actually fall within what is quote unquote a normal weight range. And I've had patients say, you know, I can fool my folks just by holding on to a wrapper. They think I've eaten something and they don't even know. So it's important to recognize individuals with eating disorders are very effective at hiding what their behaviors are, what the symptoms are, what the signs are. They should probably work for the Secret Service. They are such experts at espionage. Eating disorders are caused by unhealthy and unrealistic images in the media. This is one that I think maybe I want to give a little help, some historical perspective about eating disorders, maybe to help you with your answer. And the reality is the earliest known case of an eating disorder, anorexia nervosa, was actually cited by Sir Richard Morton in 1686. He described in his medical journals a 20-year-old patient that he was treating with severe emaciation. A couple hundred years later, even 1868, Sir William Gull described a strange malady that he originally called apepsia hysterica, which affected young women who refused to eat, even though they were becoming extremely emaciated. He continued to do research on this, and 6 years later, he renamed the illness anorexia nervosa. So, you know, the media, for what it does, I mean, print media, television, movies, social media, all of these can certainly contribute to the development, but eating disorders are multifactorial. So the answer is false. They've been documented for so long. It's just one of those illnesses that we just don't hear about a lot. Another study that was done in the 90s that was actually rather interesting, they brought television to the Fiji Islands, where previously for generations there had been really no Western civilization contact with the islanders. And they discovered that in a very short amount of time, I think approximately 5-6 years, the young female individuals that were living on the island started kind of modeling the behavior they were seeing reflected on the television images that they were watching. So we can certainly draw some conclusions that the media does have an impact on how individuals view their body. Eating disorders are all about food and all about body image. And of course, everyone said false. It might start out as maybe a desire to lose weight, maybe to start a diet, but the reality is eating disorders are mental illnesses that have very little to do with food, eating, or appearance all by themselves. The symptoms of eating behaviors and the preoccupation with thinness, those are really only just symptoms of other deeper psychological issues that are going on. Eating disorders are an attempt to call attention to oneself. And of course, everybody knows that's false. The great majority of patients that I've talked to are very, very much embarrassed to have individuals discover that they have an eating disorder. They're very secretive about their behaviors. They feel ashamed. They feel a strong sense of embarrassment and guilt, and they go to great extreme lengths to conceal their behaviors. They don't choose to have an eating disorder. They're not setting out to start this. You know, we have to remember that it's a complex illness. It's biological, it's psychological. There's social factors, there's spiritual factors. There's so many things involved. It's not just about calling attention to oneself. And the last question I guess I want to ask is, people can recover from an eating disorder. And I hope everybody say true. The important thing to know is that willpower and determination are certainly important factors for recovery, but they're not the only things that patients need. Recovery requires treatment, covering medical, nutritional, psychological interventions. And it's important to do this early on to get appropriate care in order to improve the outcome of an eating disorder. So, how to understand and recognize what eating disorders are. And I'm giving you this crash course. I don't expect all of you to become experts. I certainly hope, though, that everybody can take away just some new information, maybe understanding just a little bit more what's going on. If you have a loved one that's struggling with an eating disorder, that you can develop a little bit more, maybe understanding and empathy for what they're going through, and to learn ways that maybe you can offer some support and reassurance for enforcing their recovery journey. So eating disorders, if they present to individuals for treatment, if they're coming to the attention of the medical professions or psychological professionals, about 90% of them are females and about 10% are males. And again, this is only the individuals that actually present for treatment. We believe that the numbers of individuals struggling with eating disorders are much greater than what we could ever know. Of these young women who are coming for treatment, about 90% of them are between the ages of 25 and 12. You know, adolescence and to young adulthood is a prime time for eating disorders to develop with women. With young men, we're seeing it a little bit later presentation, usually around 16 to 18, post-puberty a little bit for the males. Between 5 to 20% of college females have an eating disorder or engage in disordered eating behaviors. And to distinguish that, it's understanding that eating disorders are kind of on a continuum, all the way from occasional dieting behavior or disordered eating, all the way to full-blown clinical presentation of eating disorders. And most individuals fall somewhere along that continuum, just in general. More than 10% of adolescent girls and 3% of boys have reported that they have engaged in binging or purging behaviors at least once a week, according to the Archives of Pediatric Adolescent Medicine in a study done in 2008. We're finding that younger and younger presentations of children, adolescents are occurring, and is quite disturbing. And again, shame and secrecy of the illness keeps individuals quiet, keeps the denial happening, and folks are either underreporting their illness or they're being misdiagnosed by their healthcare professionals, maybe presenting for some other medical malady that actually may be a consequence of an eating disorder. One of the most disturbing facts that we need to know, until very recently, anorexia nervosa had been recognized as the sole psychiatric disorder with the highest mortality rate, and was in line in running with opioid-related deaths. The studies that they've been doing lately have recognized that it's actually kind of they're in tie, actually. They both contribute, eating disorders as well as opioid addiction, as the most lethal psychiatric illnesses. So what does the presentation of an eating disorder look like? So I'll take apart each diagnosis bit by bit to help kind of explain what they are. Anorexia nervosa, probably one of the most familiar to individuals. It's characterized by significantly low body weight, usually as a result of restricting energy or food intake. It's characterized by an intense fear of gaining weight and distorted body image. So individuals who may be severely emaciated will vehemently deny that they are. Their brain tells them that they're not. There's an extreme focus on shape and weight. The number on the scale becomes all meaningful to them. And again, denying the seriousness of the illness. Most folks will tell you, no, really, I'm fine. Diagnostically, what we've more recently done is kind of break out anorexia into two different types, purely restricting type as well as the purging type. And it's important to kind of distinguish that the purging type is distinct from bulimia nervosa. It's primarily going to be individuals who are still restricting the amount of food that they're eating. They're not meeting their expected weight goals for their size, but they're purging what foods that they do eat. Bulimia nervosa, another one that's fairly familiar for most folks. People engage in recurrent binge eating and purging episodes. A binge is objectively described as a large amount of food eaten in a short amount of time by most folks' social comparisons. So eating more than would feel normal at a meal. The experience of feeling out of control with the food that they are eating, and then engaging in compensatory behaviors. So doing something to undo the quote unquote damage that they've done by engaging in the binge behavior. So they're going to engage in vomiting, laxative abuse, diuretic abuse, obsessive or excessive exercise, or restricting and fasting behaviors. Like anorexia, there's also an extreme focus on shape and weight. And diagnostically for bulimia nervosa, the behavior should occur on average once a week for at least 3 months. Prior to DSM-5, the Diagnostic and Statistical Manual, 5th edition, which is used to provide diagnostic criteria for mental health illnesses. That was in 2013 for the 5th version. Atypical eating disorder behaviors fell under an umbrella called EDNOS, or eating disorder not otherwise specified. And behaviors in this category were primarily seen as less serious or of no great concern. But since that time, we've really come to recognize that these EDNOS, these otherwise not specified illnesses, are actually quite serious. And so many of them have been given full diagnostic credibility on their own. So binge eating disorder has come under its own diagnostic category. And it is, in fact, actually one of the most prevalent eating disorders that there is. It's characterized by, again, recurrent binge eating episodes, eating a large amount of food with that sense of loss of control. However, there is no compensatory behavior like bulimia nervosa. So with that, what we find are folks reporting that they eat much faster than normal. They're eating until they're uncomfortably full. Again, eating a large amount of food, but they're not physically really hungry, and eating usually alone out of embarrassment or shame, and reporting feelings of disgust, depression, and severe guilt. And for BED, the diagnosis needs to occur, the behavior needs to be occurring at least 2 days a week for about 6 months. Other diagnoses that have come into awareness, OSFED, other specified feeding or eating disorder. Again, this kind of is an umbrella. It characterizes several different sort of behavior, satellite behaviors. So it is, again, significant eating disorder, but it's generally those that don't meet full criteria for anorexia nervosa or bulimia nervosa or binge eating disorder. For instance, purging disorder, which is a purging behavior, again, to influence weight and shape, but not with binging. So it's individuals who are eating normal amounts of food every meal, but they're just purging whatever they eat at each of these meals. Atypical anorexia nervosa, again, meeting all the criteria for anorexia except the significant weight loss. So this is actually probably even more serious sometimes because it goes under the radar for many medical doctors. They don't recognize this illness because the weight is generally within normal range. Oftentimes it can even be in individuals living in larger sized bodies. And what's important is to understand that for all of our eating disorders, what we're concerned about is not necessarily just the number on a scale, not the weight, but the behaviors that people are engaging in. And so severe restriction, severe malnourishment in any body, no matter the size, is completely contraindicated. It's concerning and it's medically serious. So even somebody that may be in what somebody might consider in an obese category, losing a significant amount of weight, even if they're still in a larger body at the end of that weight loss, the damage that can be done medically to all the systems in their body is just too great to go unrecognized. And so we need to really look at the behavior, to recognize the word anorexia means without appetite. And that can be related to a lot of things, not just anorexia nervosa. Another label, diabulimia, it's not technically a DSM diagnosis, but it is a serious behavior in and of itself. And that is about individuals who have diabetes, type 1 diabetes, who intentionally omit or manipulate their insulin intake in order to manage their weight in some way. Another illness that's often kind of passed around is becoming a hot label is orthorexia, which again is not really a diagnosis. It's not a diagnosis of itself, but it's a pursuit of clean eating. And again, this is quite serious. It is generally a precursor to what we see with individuals who then go on to develop anorexia nervosa. And another diagnostic criteria, avoidant restrictive food intake disorder called ARFID. A lot of individuals with this presentation, maybe are experiencing other related weight loss or failure to thrive issues. So they're not getting their appropriate nutrition or energy needs due to a variety of reasons. It could be because of nutritional variety, lack of variety. Maybe there are textural issues. There might be a secondary diagnosis, maybe on the autism spectrum, where maybe their variety of food that feels comfortable and safe is very limited. And so their nutritional experience is compromised as a result. So there's also usually then some concern about how they're interacting with individuals socially. So they're isolating themselves and they're not engaging in normal sort of social food experiences with individuals. This is also something that's not connected to a medical reason. So it's not about maybe having had surgery for some other illness, some GI experience, or maybe a dental experience where they're losing weight and they've lost interest in food. This is something in and of itself. Again, it's can be a very serious eating disorder. Something that we think about in terms of how to recognize eating disorders is also about the temperament of individuals, meaning their personality, what style of engagement they have with folks in their world, in their life. And so when we think about folks with anorexia nervosa, they are very independent individuals, are very intelligent individuals, very perfectionistic with high aspirations, but they also tend to be very harm avoidant and nervous, anxious individuals. There may be qualities of obsessional sort of behaviors, maybe needing things to be very just so perfect. They're also very reward dependent. They seek approval and appreciation from individuals, whether teachers or loved ones. They're very, again, harm avoidant, so their novelty seeking is very, very low. And additionally, their self-esteem is also quite low. For folks with bulimia nervosa, very similar to individuals with anorexia. Again, harm avoidant, nervous, anxious, perfectionistic, and obsessional are all qualities that we see with many individuals. Again, also very highly intelligent and high achieving, but their self-esteem is so very low as well. But they also are different in a sense of high novelty seeking. They can be very impulsive, a little sensation seeking, maybe some risky driving, some risky behavior, more likely to engage in substance use than somebody with anorexia nervosa. And their emotions tend to be a little bit more kind of dysregulated, or at times kind of topsy-turvy. And then individuals with binge eating disorder, again, all the individuals with eating disorders have some strong similarities, that desire to avoid harm, being very emotionally sensitive individuals with low self-esteem at times, but they're also seeking some sense of purpose in the world. They're struggling in how to connect with individuals. They're emotionally sensitive. Their emotions are very reactive. And so, you know, we're finding that they tend to just kind of isolate and stay to themselves out of fear of upsetting the world or causing any difficulties for themselves. So how do we kind of, you know, look at and find the common factors among the different eating disorders? Because they're all similar, they're all different, and there's so many crossovers. You know, they're biological, they're psychological, they're social, they're spiritual, they're environmental. There are so many things that interplay and cross over. And so we can't generally say any one thing, any one experience criteria is going to identify somebody as having an eating disorder. And in fact, sometimes we see, you know, maybe a strong correlation among family members, you know, all the generations of women, there might be individuals struggling with an eating disorder, or maybe they have similar, you know, difficulties with maybe that temperament, that sensation seeking, but it's expressed in different ways. So maybe there's drug abuse or alcohol abuse, or engaging in, you know, maybe some petty larceny or something like that, as well as, you know, an eating disorder. So we can't per se one thing does lead somebody to have an eating disorder. Sometimes it's said that, you know, genetics loads the gun, and the environment, the experiences that people have pulls the trigger for why somebody develops an eating disorder, when, you know, only one person in a family out of several siblings and nobody else has one. You know, individual factors, traumas, stresses, change, things that can be going on in somebody's life, you know, we don't know. What, you know, when we think about change and stresses, you know, earlier slide, I'd said that 90% of young women who develop an eating disorder are doing so between the ages of 12 and 25. And so we think about what's happening at these ages. And, you know, the first thing that comes to mind is, you know, puberty. And so, you know, what's not happening during these years? This is such a difficult time just for a normal, you know, quote unquote, normal kid. You know, what we don't recognize, what we don't think about is that about this time, you know, 20% of an individual's adult height is starting to develop, and 50% of what their adult weight is expected to, you know, they're expected to gain that during these years. And so many things are changing in the body that can contribute to this. What's going on? Sorry about that. You know, we have to consider, you know, all the factors that can be going on. And again, you know, socially, what's happening? Are they in competitive or academic sports? Are they in sports that encourage weight, you know, criteria, you know, wrestling, gymnastics, dance, track and field? And are they engaged in maybe the diet culture or the media that's, you know, telling them, you know, who their role models might want to be for them? So again, a lot of comorbid diagnoses could be happening for individuals. Again, having an eating disorder doesn't mean that you're not going to be affected by things like depression, anxiety, obsessive compulsive disorder, trauma, substance abuse. What we do see is that a lot of folks have maybe both. 50 to 75% of individuals with an eating disorder have depression as well, and 43% of our individuals have anxiety disorders as well. So what will oftentimes happen is what we call whack-a-mole, where we start treating the eating disorder, and maybe one of these other behaviors, one of these other disorders is going to kind of rear up a little bit more. So maybe they're starting to experience their emotions, but they don't want to experience their emotions because they're too powerful, they're too overwhelming for them, and so they don't know how to manage that. So again, that's where the functionality of the eating disorder came into play. It's that helped them kind of keep things contained and under wraps, that sense of control that they were looking for. So we have to be mindful about what the emotional difficulties that could also be going on hand in hand with the eating disorder. Why is there so much comorbidity? For a lot of folks, the eating disorder seemed like it was a reasonable solution for a problem, to give them that sense of control over their life, over a particular problem, and then it became its own problem. So we don't know, did the psychopathology increase the risk of eating disorders? Were they depressed already and that led them to have the eating disorder? Or is it a consequence of having the eating disorder that they're becoming depressed? Or are they both caused by the same maybe underlying things that are happening in somebody's life, like maybe relationship issues or academic issues or work-related issues? And then pathoplasty, which is really kind of looking at the relationship, being that one dispositional variable is associated with the expression of another one. So again, that chicken or the egg, we don't know which is going first and which is the secondary result. And my thought is, why are we worrying about the which one, but let's treat them both. We have to understand that eating disorders are not just about the food. So again, they're coping skills, albeit maybe dysfunctional skills, for more serious and painful issues that are underlying what's going on for an individual. So again, giving that sense of control in life. When life feels chaotic, this is something that they can count on. It might offer a sense of soothing or comfort, a way that maybe they don't know how to experience their emotions, so they can numb themselves with this. They can sedate their high emotions and distract from the pain that they're feeling. If they don't have words to express what they want to say, sometimes the behaviors are going to be the best language that they have. So it's a way of discharging tension or anger or rebellion. It's a way of reacting to things that they, again, don't want to engage in or participate in, but they don't know how to not do that. They don't know how to say no. Eating disorders also provide a sense of predictability and structure. They can be a form of self-punishment, a way of avoiding things in life, maturity or intimacy, a fear of failure, a fear of success. I've had patients say, I don't want to grow up. I've seen what adults go through. I don't like it. I don't want any part of that. You can't make me grow up. So if I don't eat, I don't grow. And if I don't grow, then I don't have to function in the world. And other people can take care of me. And until that doesn't happen, until that's not the way it works. We have to help people. That's, part of what our philosophy is to help people find their identity, their true sense of who they are apart from that eating disorder. They're more than just those behaviors. So how do we respond to eating disorders? So if you have a friend or a loved one that's struggling, and you need to know you don't have to do this alone. The best way to help is to try and get early diagnosis, to find a referral for a treatment team. I can't say it enough. Developing an eating disorder is not a choice. People suffering from eating disorders don't understand the severity of their illness, and they're reluctant to seek help. They don't want to cause trouble. They don't want to be a bother. They didn't set out to have this eating disorder. They didn't, say, okay, how can I impact the course of my you know, the growth of my hair or how my teeth are, or, you know, the texture of my skin. They're not thinking about what those consequences are, you know, the heart arrhythmia that's developing, or the difficulty with being able to, you know, have normal gastrointestinal health. You know, the important thing is to pursue intervention strategies, getting educated about eating disorders, and doing appropriate proper screening to help prevent chronic malnutrition and the long-term health consequences. And, you know, in some cases, even death. We're trying to prevent people from dying. So in other words, detecting and treating eating disorders as soon as possible has the potential to save people's lives. You know, early intervention, again, will lead to, you know, a speedy recovery, reducing symptoms, staying free of the illness. For example, when adolescents with anorexia were given a family-based treatment within the first 3 years of being diagnosed and the onset of their illness, they had a greater likelihood of full recovery and living a very healthy kind of quote unquote normal adult life. You know, but when eating disorders are untreated, they become more severe, more chronic, and they're less responsive to treatment. You know, eating disorders are unique among the mental disorders. They manifest with physical complications, and these can lead to serious life-threatening illnesses such as diabetes, cancer, organ failure, and even death if not treated. Again, anorexia nervosa is the third most common chronic illness among adolescents, and young women who have this have a 12-time higher rate than the average of premature mortality. You know, so we really have to look at early interventions, starting with education, starting with screening. Screening is not intended to be diagnostic, but just to help individuals be identified who are at risk for possibly developing an eating disorder, and maybe provide some information about resources that are available in their community, how to find help. Diagnosis should be done by, you know, trained health professionals, ideally an eating disorder specialist, because treatment's going to involve a variety of individuals, disciplines, you know, medical professionals, nutritional professionals, you know, family medicine, psychiatry, you know, psychology, everything involved in this. So we have to look, you know, at where can we start bringing in interventions. So the question comes, when should we refer somebody for a higher level of care? And so, you know, certainly when we're noticing weight changes that are of concern, you know, rapid or persistent decline in food intake, loss of control over their behaviors, lack of progress with specialized, you know, care, you know, failure at maybe an outpatient level, co-occurring illnesses, again, substance use, severe anxiety, suicide intentionality, or, you know, obsessive compulsive disorder, individuals that are requiring supervision at their meals, and then medical complications that might require some stabilization. Some goals, things that we're looking for when we're going to be doing treatment. Again, nutritional rehabilitation, normalizing eating behaviors, helping to move thinking about weight into more healthy, you know, trajectory, not thinking in terms of good food, bad food. You know, there's a variety of foods that we can all enjoy in a variety of times. And so, you know, all foods in moderation, everything is open to interpretation of, you know, what your preferences are, or, you know, what food is, but it should be about, you know, getting that variety and not feeling constrained by, you know, food rules arbitrarily or otherwise. You know, nutrition rehabilitation, we have to think in terms of food as medicine. We're not going to think well if our brain is malnourished. We're not going to live well if our body is malnourished. And so we have to be able to look at that first and foremost before we can do psychology, before we can do any kind of therapy, getting nutritional rehabilitation on board for patients. Some questions that, you know, we certainly wouldn't ask family members necessarily to be thinking in these terms of, what to ask your loved ones. But, some things to keep in mind as you're contemplating, does this loved one have an eating disorder? Are they struggling? Are they spending how much of their time, during a day thinking about weight, shape, or food? Or have they been attempting to manipulate what they're taking in order to change their body? Do they ever eat in secret or feel ashamed about eating with others, or what they look like when they're out socializing with their friends and they're at a food themed event? Or are they compensating in some way using food restriction or purging behaviors or over exercising, or telling themselves that unless they do these exercises that they don't deserve to eat? Some other considerations, when thinking about people that you're concerned about who might have an eating disorder, if you suspect that, avoid advice giving, just kind of stick to the focus of what you're seeing, how the behaviors maybe are impacting the person's life, their well-being, that, gosh, we miss seeing you at, the gatherings at game night, and, you haven't been going out to dinner with us. We've invited you to dinner and you keep declining. I'm worried about you. I'm concerned about you. It's important to avoid arguments with people. It gets to be a challenge of how to not make accusatory or judgmental statements or language, but it's not going to help to get into a butting heads battle of what you're seeing and what the person is reporting. And so if it's not going anywhere, it's best to maybe stop the conversation, to say, maybe we need to agree to disagree on this, and seek out some additional referrals to help you with your loved one. It's important to, consult with professionals who specialize in eating disorders. Eating disorders can be an emergency, and, we don't want you to feel like you're kind of swimming alone with sharks. Get help. But you can't necessarily, again, know or assume or diagnose, what you're seeing. You can't tell if somebody has an eating disorder. So again, it's important not to label. It's not, you're not in a position to diagnose. That's what professionals are there to do. Your job is not to police what the meals are, but just to express concern and to communicate that you want to provide some care and that you want to provide help for your loved one, to find support and resources to help them through this difficult time. You also want to be mindful about your boundaries. Again, not overstepping, where you start and where they start, and, minding your P's and Q's. So, try and pass the next slide. So some do's and don'ts for family members and therapists, things to keep in mind. Too many people fear saying or doing the wrong thing out of fear for making things worse. So instead, they don't say or do anything at all. It's that walking on eggshells feeling that we don't like. So maybe here's some guidelines, things for therapists or family members to consider. There isn't a quick fix. There's no easy solution for eating disorders. So, even though somebody maybe does find their way to treatment and they engage in a full course of treatment, that may not cure their eating disorder. There may be quite a bit of work still to do. Eating disorders didn't develop overnight. They're not going to go away overnight. We want to be mindful about that. We don't want to force anything upon anyone. So, we can't ignore the problem, but we also don't want to give up. So we want to encourage the person to seek professional assessment. We want to remind them that, we're concerned, that we have an interest in seeing them get well. We want to provide resources where we can. And we want to just kind of be mindful about what our limitations are. Want to kind of address a little bit about EDCare. We're a multidisciplinary kind of treatment program. And so we encourage our folks, our patients, to empower themselves and we endorse this empowerment-based treatment philosophy. And so what CAMSA engenders for folks is to create an opportunity for connection among individuals and within groups, to develop a sense of acceptance that they have an eating disorder, and working towards accepting who they are as unique individuals with their own desires and strengths and weaknesses and relationships, to develop a sense of mindfulness and a sense of self, to be mindful and connected in the moment, to be considering their recovery path and taking a non-judgmental stance in their daily life, and working towards building an authentic life apart from their eating disorder. And then taking action, learning how to launch themselves into that, again, recovery-focused life, to sustain that for themselves. So we help people get a lot of practice in doing that while they're in treatment here with their team, and encourage them to continue doing that as they step to outpatient level. There are a variety of levels of care, level 1 to level 6, outpatient, intensive outpatient, partial hospital, residential, inpatient, hospitalization, and acute medical. At EDCare, we offer outpatient, intensive outpatient, and partial hospital. Higher levels of care beyond that are residential treatment, inpatient, and acute medical. Those are sometimes confusing for people to understand what those really look like. Residential is different than partial hospital. It's 24/7 care. There's staff overnight with the patients, monitoring what's happening, supporting them, encouraging recovery. They're engaged in groups all day. There's opportunities for practice, much like at PHP, but a little bit more intensive. There's a lot more engagement with family support. This is different than inpatient, which is going to be much more medical oversight. Generally, there's no groups or individual programming that's going on. And length of stay is going to be usually fairly brief. It's about stabilization for medical things. It's going to be days versus weeks. And acute medical care is for individuals who are very, very severely medically compromised. Their illness requires really, bed stay, as opposed to being able to engage in normal activities. So at EDCare, here's a little bit about our different locations. Denver, Colorado, and Colorado Springs offer different levels. There's PHP and IOP in Denver, and then evening IOP at both Colorado and Denver and Colorado Springs. And then Colorado Springs has the adolescent as well as outpatient level. Here in Overland Park, we have PHP and IOP and evening adult and adolescent IOP. And then in Nebraska and Omaha, they have the evening IOP for adults, and then a BED focused IOP program as well. So some of the different levels of care, kind of describing those. So the adolescent intensive programs are for 13, 14 to 17, 18-year-olds. It's 4 days a week, 3 hours a day. It's generally a step down from PHP. And the patients are ready to start practicing skills. They're receiving, family therapy, individual therapy, nutrition, counseling. They're getting supported meals. They're engaged with experiential groups and evidence-based groups, ACT, DBT, CBT, art therapy. Similarly, in the adult evening program, this is for adults 18 and up. It's Monday through Thursday, again, 4.5 hours. Very similar kind of experience as the adolescent program, with the experiential and evidence-based groups, individual therapy, individual dietary focus. In both the evening programs, there's no medical supervision with them. They're still engaged with their medical outpatient providers. In PHP, that's a little more intensive. In Colorado, in Denver, it's a 7-day-a-week program. Here in Kansas City, it's a 6-day-a-week program. It's 10 hours a day, 6 days a week, 7 days a week. Medical evaluation is happening. Psychiatry is available. Patients are participating in individual sessions twice a week. Psychiatry family therapy, nutritional therapy, all once a week, group therapy, there are 20 different groups all through the week that folks are engaged in, plus some opportunities to practice some more real life skills, such as meal outings or innings, some social activities, learning how to maybe practice shopping for clothing in an environment without focusing on size and shape. And then the ability from PHP to step down to an intensive outpatient program. So again, 6 or 7 days a week, it's a 6-hour day, more opportunity to practice meals on their own while still receiving, medical and psychiatric interventions during the week, as well as individual, family, and nutrition therapy. I'm trying to be mindful of time. How am I doing here, Kim?
You're doing great, Dr. Swearngin. We're just at about 10 till, so we have about 10 minutes left.
Okay.
Yeah.
So kind of my last slide, I do want to recognize there's a lot of resources. As I said earlier, education about eating disorders is important. And so if you're struggling with an eating disorder, if your loved one's struggling with an eating disorder, learning as much as you can about them is important and helpful to recognize how, again, complex and complicated that they are. So there's these lovely organizations here that I have on my slide that are involved in supporting patients and their family members and their loved ones and treatment providers to be able to have resources for, overcoming and maybe eradicating eating disorders. I'd love to see that happen. So, as our sponsor for National Eating Disorders Awareness Week, we have NEDA, the National Eating Disorder Association, as well as Project HEAL, the Academy for Eating Disorders, the International Association of Eating Disorders Professionals, the ANAD, the National Association of Anorexia Nervosa and Associated Disorders, the Eating Disorder Foundation, and the Eating Disorder Hope. All of these organizations have so many professionals, much like myself and our team here, who are just focused on helping individuals recover from eating disorders and live a life free from their struggles. So I'll just kind of leave that, but so thanks for allowing me to have a bit of your time this afternoon. And I guess, I don't know if there's any questions or anything, Kim.
Yeah, there are. We have some really great questions, and we'll try to get to as many of these as we can. And if we don't happen to get to your questions tonight, we will make sure that we do get answers to these, and we'll try to follow up. If your question came in as anonymous and we don't get in to that question, please message me. I put my email in the chat, and I'd be happy to get those to Dr. Swearngin, and we can follow up with you with an answer.
Absolutely.
So with that, Dr. Swearngin, I'll start with the first one, and I'm going to paraphrase this a bit. So the question is, how can I get my 18-year-old daughter to engage with a dietitian or therapist? She cancels appointments. She has had peritonsillar abscess twice since starting college in September, and lives away from home. It sounds like the parent is trying to encourage the daughter to engage, but not willing to. And she was diagnosed with anorexia nervosa when she was 12 years old.
Okay, wow. So that's a really difficult position to be in, with kind of the launched pseudo-adult, late adolescent, early young adult individual who's away at college. It's really important to remember kind of what the roles are, and that even though they're 18 years old, quote unquote adult, they're still your child. And so you're, of course, still very concerned, but you also have some leverage sometimes with this to be able to say, your health is much, much more important than what's going on at school. And, I'm concerned about what's happening all around. And so if they're struggling with school, if their health is at at risk. If it were something else, they would probably more than willing, if they were diagnosed with cancer, to say, I need to get treatment, I need, medical attention. And so you have to think of this as no different. This is equally serious and potentially just as lethal. And so saying, no, your health is much, much more important to me. School will be there. Talking with the school about finding out how they could maybe take a pause from school, getting an educational leave of absence to seek out treatment. I'm not above saying, if you have some leverage, financial leverage, pull back some privileges. I'm unwilling to pay for your time away at school if you're unwilling to go to the dietitian's appointments. It's your health is much more important to me. You're paying for who's paying for the cell phone, who's paying for the car, how are they there? And so looking at what possible, consequences that you have leverage to offer. If the situation is even more dire, it is entirely possible to seek like a medical power of attorney over somebody who's not making good choices for themselves. And so it may be important to seek out some information and referral about pursuing that if the case escalates. I hope that's helpful.
Thank you. That was. Thank you very much. Let me move on to the next one. How do you know what level of treatment your loved one needs?
Wow, that can be a super question, and I've tried to do this so it's not too tough. So like outpatient care, that's the lowest level of care. We want to think about people who are medically stable. They don't really need regular lab work. They have pretty good motivation. Their weight is above 85% of ideal body weight, per the standards of the medical community. They seem to be pretty self-sufficient, and that their symptoms with other diagnoses are mild to moderate. They're managing with psychiatry well. They're taking, they're getting their meal plan in. They're not engaged in behaviors actively, and they're able, to get support from family and friends. So they're okay for outpatient. But if they start struggling with that, maybe, like IOP, there's going to be some, maybe their weight is dropping. Maybe they need some more structure. They need more weight restoration. Maybe the other symptoms, the depression, the anxiety are starting to escalate. And so maybe that's contributing to the eating disorder. Maybe they need more accountability around behaviors. Maybe they're engaging in excessive exercise and they're unable to interrupt that. They're maybe pulling back from social experiences. So maybe IOP would be important. With PHP, they need medical stabilization. So, maybe there's some medical concerns that need to be checked into. Their body weight is dropping, below 85%. They have low motivation. Maybe depression and anxiety are becoming even more forward than the eating disorder. Sometimes they need supervision in order to interrupt their behaviors. They're not engaging in their meals without support. So, they're going to need that interruption of behaviors at PHP level. They also need to be willing to comply with, what the treatment program might be. So if that's a problem, or if there's limited support, maybe even higher level of care would be needed. So, we want to be able to see that they can participate in groups. So they need to be able to concentrate and assume some daily responsibilities, be able to get themselves to treatment, school or work. Inpatient, again, that's folks that are unstable medically. They maybe need tube feeding or IV fluids. They need medical monitoring or hospital stay, 24 supervision. They're unable at all to interrupt the behaviors. They have zero motivation for recovery. So that's when we need to really kind of look at those different levels. Even higher, if they're passing out, dizzy, having electrolyte disturbances frequently or other medical complications like seizures or EKG disturbances, again, psychiatric status is decreasing. They need higher level of care. And so, take them in for an evaluation as soon as you can.
Excellent. Thank you, Dr. Swearngin. We're right at actually a minute over 5 o'clock. And to be respectful of everyone's time, I think we'll end everything here. I want to thank everybody again for joining us. And I know we have a few questions that have come in these last few minutes that we haven't gotten to. Again, I've entered my email in the chat. It's ktravis, Travis, at eatingdisorder.care. Please do not hesitate to email me your questions, and I'll make sure that Dr. Swearngin gets them, and we can follow up with you individually with some answers and guidance. So thank you, Dr. Swearngin, for your time. And thank you everyone for joining us. We appreciate it.
Thank you, Kim, and thank you everyone again for taking some time out of your day. And I'm happy. I'm here as a resource. If anybody ever wants to reach out, I'd be happy to talk with you further about it.
Thank you. Have a good night, everyone.
Thank you.